And now I will turn it over to Dr. Varun Chaudhary, who is the National Behavioral Health Chief Medical Officer for Magellan Health. Thank you.
Thank you, Jenny. Let me pull up my screen. Today, I'll be sharing with you our digital virtual care solution tools. And just a little bit about me. I'm a board-certified forensic psychiatrist and have been in managed care for about 7 years now. And most of it has been spent with Magellan. And I'm currently Magellan's National Behavioral Health CMO. So slide 1, this is to tell you a little bit about our company. Magellan has specialized in behavioral health for over 40 years, and we're committed to connecting behavioral health with physical health, pharmacy, and social needs with evidence-based clinical and community support programs to ensure healthcare services are coordinated and value-based. We are provider-centric, clinician-focused, and member-driven in our approach. I'd like to talk to you today about virtual care solutions, which is our digital technology solutions called ontobetterhealth.com. And this is a fully packaged virtual care solution. The users can go in and take a SmartScreener, and I'll explain about that a little later. And this tool will then allow them to get a personalized plan that includes educational resources, access to our digital CBT modules, and that they get a triage level of assessment as well. Users can also choose additional features online to make it a more robust experience, including speaking to a live chat clinician. Also, if needed, there could be a provider search to link the individual to a telehealth screener or evaluation. The important part of this is that we know with screening populations, about 8 to 10% of those individuals will screen high risk. And it is our belief that those individuals should not be left in cyberspace on their own. So we developed an option for high risk individuals to be sent to our case management team, who reach out and triage and help that individual. So I'd like to speak to you about our SmartScreener. And this is something that we're very excited about. What we found was that there was often a delay between the onset of symptoms and when an individual was looking and seeking treatment. In response to this, Magellan developed our SmartScreener capabilities. And this can quickly access an individual's symptoms and guide them in the right resources. The software is considered quote unquote smart because it uses an algorithm to screen individuals. And what we do is we start with a short version of a scale, for example, the PHQ-2 for depression. And then the SmartScreener will skip to the next set of questions if there are no indications of that condition. If the user does yield a positive indication for the condition, then the technology moves to the next questions all the way up to the PHQ-9. Our SmartScreener has 6 validated behavioral health measure tools that mirror the modules. So we offer a depression screener with PHQ-2 and PHQ-9, anxiety with G87, insomnia with the ISI, substance use with audit and DAST, and PEG use for pain. That's kind of why we call it a SmartScreener, because it optimizes the user experience. And the SmartScreener can be as short as 9 questions for an individual with no symptoms, and as long as 43 questions for the sickest individuals. Once a user goes through the SmartScreener, they come to this page. It's called My Plan page. And essentially what it will help them do is look to see what the next steps are. And from this point, the user can go to recommended DCBT programs, a resource library, or they can download the mobile app from Apple or an Android device at no cost. This is an overview of our digital cognitive behavioral therapy program suite. Many people are familiar with CBT, but by a background, CBT therapy is actually a short-term goal-oriented methodology that many behavioral health clinicians use to help individuals reduce negative thoughts and behaviors and build new skills. CBT is considered the first-line treatment for depression and anxiety, but it's also highly effective in other conditions like substance abuse and insomnia. Magellan offers 6 modules targeting depression, anxiety, OCD, substance use disorder, insomnia, and chronic pain. And we offer a full suite, as many of these conditions are highly comorbid with one another. As an example, depression can be comorbid with substance use disorders or chronic pain. And so by offering a full suite of modules, it really allows for a more holistic approach to the member's care. We use CBT modules as an intervention for members with low to moderate risk behavioral health conditions, and consider the modules not only to be an intervention, but an important bridge for those individuals who are wanting to see an outpatient provider and have to wait several weeks to get that appointment. This will actually help the member start with an evidence-based care option immediately. And the other benefits are that it can be done in the privacy of a member's home, thereby reducing the stigma associated with mental health care. It's particularly useful for seniors that have mobility issues or transportation issues to access an evidence-based intervention. So just wanted to tell you a little bit more about DCBT, its impacts and efficacy. Magellan's fortunate to be one of the only MBHOs to offer a full suite of online cognitive behavioral therapy modules. The modules have been highly studied and tested in 24 different randomized control trials with more than 1,000 participants. The research has yielded good results. The modules have been shown to be effective in improving clinical symptoms and shown to be as effective as medication or face-to-face visits for certain conditions. Our modules have also been reviewed by SAMHSA and the NIH, as well as American Academy of Sleep Medicine, and recognized for excellence in care. Just some statistics to highlight on these. Those engaged in depression modules on average experience a 52% reduction in clinical symptoms as measured by the PHQ-9. Those with anxiety experience on average 63% reduction in symptoms as measured in the GAD-7. So these are very effective tools and very useful as well. Next, we wanted to give you a little bit of an overview of what we did in response to COVID-19. We quickly got our IT folks and our clinical folks together to be able to offer Restore to the general public. And Restore is our module that has to do with sleep issues and insomnia. And it was found to be very effective previously for insomnia, so we thought this would be a good way to try to help people in this time of need. And as of 5/18/20, we had 318 unique users who self-registered for the program, and 137 of them completed at least one session. We also want to highlight that we are going to be working on an expansion into pediatric and adolescents. Right now, we are trying to get our next app ready to go, or our digital CBT module ready to go. We're also working on a couple of other solutions. But currently, the SmartScreener can be used to identify anxiety, depression, and trauma among the pediatric and adolescent population. And the digital CBT modules for pediatric adolescent anxiety with the companion caregiver program can be accessed 24/7. We've also done a lot of virtual programs, and this is an example of supporting youth via tech. And we had a My Life Empowerment program, and this one was in May, but the next one actually is this week, I believe it's tomorrow. And what we have done is really leveraging tech to help those youth that are stuck at home and really are probably going stir crazy. But it is no cost weekly event. We've got national, international recognized speakers and feature youth leaders and activists. That is the end of my presentation. What I'd like to do now is hand it over to Dr. Cecilia Leafsey from Penn Medicine to give us her presentation. Thank you.
Thanks very much. Let me just share my screen here. Great. So I'm a psychiatrist at Penn, and I run our integrated mental health services. I've had the pleasure of partnering with Dr. Kallega and Independence Blue Cross on our collaborative care program. But today I really want to talk about integrated care across the care continuum. There we go. First, when you look at the data at Penn, you see a striking story. 30% of our 2 million patients have behavioral health comorbidities, and these patients have high utilization and poor clinical outcomes. They increase provider burnout and total cost of care. And we, like everyone, are grappling with a broken system. Most mental illness is treatable, and yet these patients go undiagnosed for an average of a decade and die 10 to 25 years younger, often from physical comorbidities. As Dr. Kallega was saying, access to care is poor, quality is variable, stigma is high, and reimbursement is typically low. And this is a population whose motivation and decision-making are often compromised by their illness, and yet we're asking them to navigate an increasingly challenging healthcare landscape. And now with the twin tragedies of COVID and the aftermath of George Floyd, I think the stakes couldn't be higher. The good news is that the landscape is shifting somewhat. We're able to leverage data to identify people earlier. The culture is more accepting of behavioral health needs. And as we saw from Independence's data, millennials are seeking care at record numbers. We also have new ways of reimbursing for mental health, such as the collaborative care codes. So to take advantage of these new opportunities, we needed to move from reactive to proactive engagement with novel data sources, from siloed to integrated care delivery with evidence-based treatments, and from sporadic to continuous support for these chronic illnesses. And we also needed robust informatics, virtual and self-directed care, and an administrative infrastructure. So we've started several integrated programs at Penn, and the first is MEND, which will be my focus. MEND stands for Mental Health Engagement, Navigation, and Delivery, and it's a proactive mental health team that's embedded in Penn's hospitals on their general medicine floors. We started MEND knowing three things. First, mental health care in the hospital was limited. In the year prior to MEND, we only saw 1,000 psychiatry consults, but we calculated that there should have been at least 10,000. Second, patients with mental health diagnoses were staying 22% longer, which is an extra 30 hours. And third, these patients were not just being held there longer, they were literally being held there. Our patients spent more than 500,000 hours in restraints. And we discovered that this problem struck at the heart of our providers. 98% felt that their ability to provide care was compromised by patients with mental health comorbidities. They wanted to help, but felt the system was broken. So we started with step one, reactive to proactive engagement. We wanted to identify patients with mental health needs the instant they hit the hospital. So our first innovation was a machine learning algorithm. We knew that discrete data fields, such as previous diagnoses or medications given in the hospital, gave us more noise than signal. So we thought, wouldn't it be great to bring forward the words that providers use and use those? So we tried a few models, a linear regression model, which has more transparency but poorer fit, complex models like neural networks, which had a better fit but had a risk for overlearning, and eventually settled on a naive Bayes model. For the learning signal, we reviewed patient charts, identified those in need of mental health care, and trained our algorithm to be about 83% accurate. But the coolest part of the algorithm is that it's based on over 2,000 statistically significant buzzwords that we found. Some of these are expected, like depressive and suicide, but others were really unexpected, like victims or non-compliance or consequences. So step two was really moving from siloed to integrated care delivery. Our hypothesis was that by embedding a full-time nurse practitioner, a full-time social worker, but just part of a psychiatrist, we could address patient and provider needs more comprehensively and at less cost. Each morning, the MEND team uses a dashboard prioritized by this MEND algorithm risk score and triages patients to the most appropriate provider. While rounding with the medical teams, MEND offers guidance, and for patients, MEND delivers evidence-based treatments and helps them see and overcome their barriers to care. The navigation component starts on day one, planning discharge based on key variables, and also working with community organizations. We also started a bridge clinic, or urgent care psychiatry, to make transitions in care even faster and more secure. And we try to send patients back to their PCPs and enroll them in Penn Integrated Care, or PIC. So the results of our initial pilot we went from identifying 6% of patients as needing mental health care to 44%. And instead of identifying patients on day 5, as we had previously, we saw them on day 1. We treated 4 times as many patients, and we saw that everyone was performing at the top of their licensure. And we were fascinated to find that only 1 in 4 to 5 cases required our men's psychiatrist. For patients, the results have been meaningful. We've reduced the hours of restraint use. There are also fewer safety events. And importantly, we've seen a culture change. Providers are more aware of their patients' mental health needs and call men life-changing. But we needed to know that the solution could be sustainable. We were cautiously optimistic when we saw our overall length of stay decrease by close to a day, and our most vulnerable patients, our community and our Medicaid patients, had an even greater reduction. Even patients with no mental health needs left the hospital sooner, and we called that our men halo effect. So the future of men that we're planning now is algorithmic mapping of the whole hospital with the ability to smart room patients, more support for high-risk populations like new moms and elderly patients who become delirious after surgery, and rapid response behavioral teams to help with agitated patients and ensure staff safety, and a seamless extension to outpatient care, home care, and virtual care. So moving to outpatient, I'll give you a very quick overview of Penn Integrated Care, which, as Dr. Kallega said, is based on the collaborative care model in primary care, a model which has been around for 15 years with over 80 randomized controlled trials showing efficacy. We identify patients through screening, through the primary care's clinical judgment, or through proactive reports that look at high-risk comorbidities like heart disease and depression, or lung disease and anxiety. The primary care doctor remains the point person on the team, and there's an embedded licensed clinical social worker who supports this provider by delivering behavioral interventions in the practice. And the consulting psychiatrist works with the licensed clinical social worker and with the primary care doctor on treatment plans and medication adjustments. To navigate patients to the right side of care, we have a virtual resource center staffed by care coordinators who use decision support software to assess, triage, and refer patients either back to integrated care to be treated or to specialty care in the community. Our demand for the program has been explosive. 15,000 out of the 100,000 patients in the practices we're in were referred, 10,000 were enrolled and triaged to care, and 5,000 appropriately scheduled for collaborative care back in the practice. We also caught 1,500 patients who were actively suicidal and may have otherwise fallen through the cracks. Our depression and anxiety remission scores rival controlled research studies at close to 50%, and we're beginning to see benefits on the physical health side with better control of diabetes and hypertension. And we're doing this with 10 times less psychiatry time than we use in our typical outpatient psychiatry services. And Independence is doing a matched analysis of total cost of care, and our preliminary findings are quite positive. And like men, providers simply love this program. So this is a really busy slide here, but what we see here is the whole continuum of integrated care. And what we're really working on now is how to support it with both community engagement, which we're calling MendX, and a virtual platform called Cobalt, which we built for our frontline healthcare workers to specifically target COVID-19 related mental health issues about 6 weeks ago. Cobalt's a virtual platform that uses algorithms to curate content and to triage our employees to individual and group sessions. Cobalt really has 3 buckets of resources: one-to-one support with peers, resilience coaches, psychotherapists, and psychiatrists, group support that ranges from mindfulness to trauma groups to substance use groups, and also self-directed content like online CBT modules. And in the first 30 days, there was an immediate demand from our frontline employees with over 5,000 users. Interestingly, 50% of them logged in anonymously, over 10,000 sessions and 50,000 page views, and a number you can't really put a value on, 50 employees who were suicidal and connected to care immediately. As a seasoned emergency room doctor said to me, she said, in my 30 years, I've never experienced even close to this type of stress, horror, uncertainty, fear, and anger. And I think that's true for everyone, but especially right now for our Black colleagues and patients and community and all of us who are grappling with a different kind of pandemic as well. So we see these programs, all of these integrated care programs, as a way to help people tolerate hard things, not get rid of them. And through care across the continuum, we want to build resilience and treat symptoms and teach self-care And our goal for all of this is really to give our employees and our patients the space and the tools to be comfortably human. And now I'm really pleased to announce Matt Miklett, the Senior Manager of Clinical Operations for NeuroFlow.
Great, thank you guys so much. If this doesn't pump you up, all this cool technology that's coming out and what's becoming available to our patients, I don't know what will, because this is better than my cup of coffee to get me going today. But as Cecilia mentioned, I'm Matt Miklett. I'm the head of clinical operations for NeuroFlow. By way of background, I come from a military clinical setting where I treated combat trauma and also led an inpatient psych unit. So I did a lot with restraint use. So incredible to see how technology is now being incorporated for these ways that we used to have to think about patient education and using policy. So the ways we're using technology now are just so incredible. So more recently for me, I've been working in mental health and substance use policy. And when I think about the problem that we're addressing today, I think most of us are pretty familiar with the behavioral health capacity issues that we face. And if not, we certainly have touched on it a bunch already this morning. The problem is that this problem is only getting worse. And even before COVID and the unrest that we face today, we knew that we could not train and hire our way out of this problem that we're facing. We need technology. We need it for prevention to slow the flow. We need earlier identification of at-risk individuals. And we need to enable care teams to more effectively deliver these evidence-based treatment models, such as collaborative care at scale. One effective approach is using stepped care. It's a way to make sure that we're getting the right patients to that right level of care. But providers often feel largely unprepared. And even if there are protocols in place, clinical workflows often don't support them. And there's often inconsistent screening and the measurements and data we need to then effectively utilize those workflows. So we help providers with that in three main ways. The first thing we're doing at NeuroFlow is to help with measurement. So when we touched a bit on some of the screeners that are used, so validated assessments such as PHQ-9 or GAD for anxiety, depression. We have a host of 20 more that are involved in our platform. We also use subjective data. So you can think about things like pain, mood, sleep, and also incorporating more and more biometrics. So thinking about things like activity data. How much is somebody getting up and actually moving? But we also know that more data is not necessarily helpful for providers. When you only have 15 minutes for a visit, you don't have time to digest all this new information. So the next thing we're doing is really helping to manage, help providers make sense of that data, provide some clinical decision support to help them understand what is the next step I should be taking with my patient, making that physical health provider who never felt comfortable treating mental health feel more empowered to take care of that patient and that whole patient. And the third thing we do is motivate. There are some incredible evidence-based treatments out there, digital cognitive behavioral therapy being one of them, but without patient adherence, you're not going to see the improved outcomes. We need patients to engage with that care and want to be involved. Our patient has two platforms. Our platform has two sides, sorry. We have a care management side, which we call our care team dashboard, and a patient-facing app. And it's also available as a web version for somebody without a smartphone or a tablet. Organizations determine what their own goals are. We work with them to determine what do they want to assess and look for. These outcomes then feed back into the care team dashboard and even help to auto-deliver individualized content back to that patient based on their outcomes. So if I screen positively for anxiety, I'm going to be getting anxiety-related content, whereas somebody else who maybe screens positive for depression or doesn't screen for anything at all will either get depression content or maybe something more like resiliency or positive psychology. We also have EHR integrations. So medical providers don't have to access our native dashboard, and instead all that discrete data and that clinical support can then feed right into that EHR where they're already utilizing. This is a real quick look at the patient-facing app. The first thing I would hope that you noticed is it doesn't look clinical. So while you need a provider or some organization tied to the platform, we built it very much with a consumer mindset. All of our engineers have came from the consumer world to make this look and feel like something that you actually want to engage with. We use behavioral economic approaches, including rewards programs. And with these strategies, we have incredibly high engagement rates. So we have 76% of our patients are staying on the platform after 6 weeks. The care team dashboard includes a number of different permission levels. What that allows for is for hospital and organizational leadership and population health leaders to view just that enterprise high-level data to better understand what's going on at their whole patient population. All of our content is also customizable. So our strategy is not to throw the kitchen sink at everybody. We want to make sure that we're using the right messaging and providing very specific organization resources to make sure that patients are not confused and just getting a bunch of information thrown at them, but feel like it's tailored to them and getting the resources that they can best utilize. We also have care team alerts to help our care teams respond in mental health crises, or to provide resources to those patients that are otherwise at risk. And our clinical decision support allows us to incorporate treatment algorithms or care pathways into the workflow to help providers understand, what do I do next with this patient based on past assessments and the current treatments that we're doing. Our ultimate goal is to help organizations incorporate behavioral health into practice. No matter where the organization is, we come in and help support and scale that effort. So it could be something as simple as coming in and doing in-clinic tablet screening, all the way to serving as that functional registry needed for collaborative care. And what's great about having a cloud-based registry now is when you need a psychiatrist or somebody else on staff, we can now have that person be remote because we have a cloud-based registry where we can now bring that person in and help support those clinics. We're supporting organizations across the country, including, we really work with 3 main populations. The first being our home, was with behavioral health specialists. We were originally designed as a tool for therapists to deliver homework assignments and be able to practice measurement-based care. But I've now moved on also to physical health settings. And we're in a number of different settings, from pain clinics. We have a specific OBGYN platform where we address postpartum depression. And we also serve population health organizations. So you think about, we're working with insurers and employers. We also have a big footprint in the military and first responder community as well. And while we know that certainly the treatments are again, the same, and there are very effective treatments that we can use, if the messaging isn't right and you don't make it feel like it's for them, they're not going to engage with it. So understanding that when it comes to military and first responders, it's much more about using language around human performance, right? And understanding security concerns and addressing those concerns that each individual population has. That's why we take the approach of working with organizations to collaborate to make an effective program for them. As for our outcomes, I want to be really clear here that our goal is to empower providers. So while we're seeing incredibly awesome numbers coming our way, we think that the numbers we're seeing here are because we're empowering the patients and the providers with NeuroFlow. It's led to patients being more engaged. I mentioned earlier that 76% are completing activities past 6 weeks. The industry standard is 10% with digital behavioral health. They're also completing 31 activities on average the first month. That means they're coming in, watching videos, tracking their mood, tracking their sleep. We're improving patient outcomes. And this is done by supporting these existing evidence-based delivery models, helping providers that never thought about measurement-based care start tracking those outcomes with their patients that are coming in month over month. And we're also providing a new revenue stream for clinics. With these new codes that came out, particularly collaborative care codes in 2018, we're offering new ways to not just incorporate behavioral health into practice, but to make it a new opportunity for that clinic, particularly during times of COVID when we need more remote options. So I really appreciate the time today. As I said, this stuff gets me super excited, so I'm really excited to have this invite. There are 2 websites here just for some free resources that certainly we've put out related to COVID-19 and provider burnout. And certainly provider burnout is an area where we're hoping to be able to help and support moving forward. But I'll leave it there, and Ginny, I'll kick it back over to you.
Thank you so much, and thank you to all of our presenters for a really fascinating conversation addressing issues around access and how we can improve access, issues around quality of care and how to improve quality of care for our patients, but also for the providers delivering that care, and then how technology can support the clinical models that are out there in the community.